Bueno, buenos días a todos. Sean ustedes bienvenidos a otro webinario, ya prácticamente los últimos de la temporada 3 y de este año. Sean ustedes bienvenidos a la Asociación Mexicana en Ultrasonografía Crítica y Urgencias con nuestra Unidad Internacional de Entrenamiento en la ciudad de Guadalajara, Jalisco. Es para nosotros un honor estar transmitiendo desde la ciudad de Monterrey, una ciudad que estuvo apaleada, apabullada desde el día de ayer con lluvias intensas, con un clima tremendo, pero afortunadamente el día de hoy estamos en mejores condiciones, listos para transmitirles desde la ciudad de Monterrey, desde París, Francia y desde la ciudad de Guadalajara. Sean ustedes bienvenidos a un webinario más. Les agradecemos de antemano su participación, todo lo que han hecho y todos a los que han participado en nuestras diferentes actividades, tanto cursos como webinarios, estamos muy agradecidos, esperando que todas estas actividades, todo nuestro esfuerzo que hemos hecho por transmitirles conocimiento de calidad, espero que les haya sido de gran utilidad con todos nuestros profesores de gran nivel, tanto locales como internacionales. Y es por eso que en esta ocasión estamos con un webinario, pues seguramente muy interesante para muchos de ustedes que trabajan en áreas críticas, como lo es el monitoreo hemodinámico, tanto invasivo como no invasivo, y en esta ocasión tenemos a un líder de opinión, tenemos a un gran médico experto en el tema, como lo es el doctor Matthew JOZWIACK desde París, Francia, quien ha estado publicando una gran cantidad de artículos junto con ese gran grupo francés que tanto ha aportado en el tema de monitoreo hemodinámico junto con otros colegas de él que de hecho también han participado en estas actividades de nuestros webinarios. Así que le estamos muy agradecidos al doctor Matthew, que en un momento se los voy a presentar, pero antes quiero presentarles a nuestro profesor local, a nuestro profesor de nuestro grupo, de nuestra asociación, a quien estamos también muy contentos de darle la bienvenida al doctor Luis Colunga, quien es médico internista y médico intensivista por parte de la Universidad de Guadalajara y se encuentra en este momento trabajando en el nuevo Hospital Civil de Guadalajara, quien es como nuestra sede. Los hospitales civiles para nosotros son como ese centro de conocimiento en el ultrasonido point of care, quienes hemos sido pioneros en nuestra República Mexicana en la enseñanza del ultrasonido, una terapia intensiva fantástica como es la del Hospital Civil de Guadalajara. Y el doctor Luis Colunga es parte de nuestro grupo, él se ha capacitado también mucho sobre el tema, él ha hecho incluso maestrías en el extranjero en la Universidad de McMaster en metodología y además el doctor Luis Colunga es parte del grupo colaborativo de la Cochrane aquí en México con sede en Guadalajara. ¿Cómo estás, Luis? Bienvenido a este webinario. ¿Cómo estás?
Buenos días, Juan. Buenos días, Matthew. Estamos con un buen clima aquí en Guadalajara, ansiosos de escuchar a nuestro magnífico ponente respecto a este tema tan interesante
Así
que lleva
es.
muchas implicaciones, tanto fisiopatológicas y específicas de cada entidad, así que será una excelente plática.
Así es. Y bueno, pues paso a presentarles a nuestro invitado, el doctor Matthew JOZWIACK, quien es médico también intensivista, que ha publicado una gran cantidad de artículos sobre el tema ahí en los centros que tienen en París, en diferentes centros. Y pues bueno, junto con sus colegas nos han regalado una vasta literatura sobre el tema. Ha publicado sobre todo esto de monitoreo hemodinámico, posición prono y infinidad de artículos de gran interés para la terapia intensiva o las áreas críticas. Dr. Matthew, thank you so much for accepting our invitation. We are very, very happy for having you. Thank you so much for sharing your knowledge. Thank you so much for having you. And let's get started with your conference, Matthew. Thank you so much.
Thank you, Antonio, for the introduction. So, hello everyone, I'm Matthew JOZWIACK, and I'm intensivist and I'm working in the medical intensive care unit of Cochrane Hospital in Paris. And it's a very great pleasure and honor to be with you from Paris right now. Thank you very much again for your invitation. Well, we are going to discuss together in the next few minutes about hemodynamic monitoring in the critically ill patient. Invasive versus non-invasive. First of all, I have no conflict of interest between. So, let's start with a very common clinical situation in critically ill patients. Arterial hypertension. In case of arterial hypertension, there are three therapeutic options: vasopressors, fluid, or in the cup. And the first question is, should we use hemodynamic monitoring to detect vasopressure, to detect effect of fluid administration, or to assess left ventricular contractility impairment? First, should we use hemodynamic monitoring to detect vasopressure? The diastolic arterial pressure is physiologically linked to heart rate. The lower the heart rate, the lower the diastolic arterial pressure. But diastolic arterial pressure is also physiologically linked to the arterial vasomotor tone. That low diastolic arterial pressure indicates vasodilation and vasophagic shock. That a diastolic arterial pressure low, for instance, below 40 millimeters of mercury, should encourage clinicians to start early vasopressure administration. So, should we use hemodynamic monitoring to detect vasopressure? No. Look at the diastolic arterial pressure. Regarding fluid administration and left ventricular contractility improvement, should we monitor cardiac health with invasive hemodynamic monitoring or non-invasive hemodynamic monitoring? Or is arterial pressure enough to assess the effects of therapy? In this study by Xavier Monet and Jean-Luc, published in 2011 in Critical Care Medicine, the effect of fluid administration and norepinephrine administration on cardiac output and on arterial pressure were assessed in 228 and 145 patients respectively. In this graph, changes in cardiac output induced by volume expansion are represented with the X, and changes in pulse pressure induced by volume expansion are represented with the Y. And as you can see, there is only a weak correlation between changes in cardiac output and changes in pulse pressure. When you consider now the changes induced by the increase in norepinephrine dosage, there was no longer correlation between changes in cardiac output and changes in pulse pressure. Thus, arterial pressure does not reflect cardiac output, and one should consider monitoring cardiac output in patient with shock. In this other study from FRANCIA and COVID, published in Intensive Care Medicine, the authors also investigated in 51 patients with septic shock the agreement between changes in cardiac output and changes in pulse pressure induced by fluid administration. In this fourth part of the analysis, changes in cardiac output are represented in the X, and changes in pulse pressure in the Y. Look first at the risk of the patient, represented by the open fibers. In some of them, whereas cardiac output increased after fluid administration, as expected, pulse pressure decreased. Now, when we look at the non-responder patient, represented by the closed fibers, again, in some of them, cardiac output did not significantly increase as expected. The pulse pressure increased in the large. In other words, there is no agreement, again, between changes in cardiac output and changes in pulse pressure. And once again, and this is my first take-home message, we should consider monitoring cardiac output in patient with shock. But should we use invasive or non-invasive hemodynamic monitoring for this purpose? Over the last decade, hemodynamic monitoring techniques have evolved from invasive toward non-invasive approaches, and from dynamism toward continuous and real-time measurement of cardiac output. Actually, the choice of the appropriate hemodynamic monitoring depends first on the phase of shock, second on the complexity of the patient, and finally on the response of the patient to the initial stress. At the initial phase of shock, all patients should have a central venous catheter inserted at least for vasopressure administration. It allows measurement of some useful variables such as central venous pressure or central venous oxygenation. Also, patients should have an arterial catheter to monitor the arterial pressure. It also provides the value of first pressure variation. Finally, when further hemodynamic assessment is needed, echocardiography is the preferred modality to initially evaluate the type of shock. Indeed, echocardiography allows rapid characterization of the type of shock. And echocardiography is now proposed as the first-line evaluation modality. For instance, echocardiography allows one to quickly identify severe left ventricular dysfunction or urgent cord pulmonale or catenate, as illustrated here by a swimming off. Echocardiography has several advantages. Of course, it's non-invasive. It allows an estimate of both cardiac structure and function. And, as I told you, it allows a rapid characterization of the type of shock. However, some patients may have poor recognition, in particular patients under mechanical ventilation. In addition, performing echocardiography requires training before being skilled enough to deal with complex cardiac disease. But it has been shown that the period of training is limited for acquiring basic skills in critical care of thoracic echocardiography, even for naive physicians. In this study we published in 2014 in Annals of Intensive Care, we assessed the learning curve for basic CT skills in 12 residents without any prior experience for CT. We used a dedicated scoring system, including the quality of echocardiographic views, but also some semi-quantitative measurements of left ventricular ejection fraction, right ventricular dilation, pericardial diffusion, and inferior vena cava diameter. We determined that a score above 14 out of 20 reliably predict full agreement regarding diagnosis and treatment between naive and echocardiography. And as you can see here, after 6 months of training, 83% of the naive residents obtained a score above 14 out of 20 after performing on average 30 TT examination per week. In my opinion, the major feature of echocardiography is that it is more a technique of hemodynamic evaluation than a technique of hemodynamic monitoring. Since you cannot continuously measure the cardiac health. Nevertheless, to overcome this limitation, we need to write transesophageal echocardiographic probe, which can be less intrusive for prolonged time without relevant side effects has been developed. And thanks to a very good quality of echocardiography, such probes could be useful for hemodynamic management of mechanically ventilated patients with shock, allowing several hemodynamic evaluations per patient, which resulted in some therapeutic changes. Finally, the precision of echocardiography should also be taken into account. We have very, very recently tested the precision of transthoracic echocardiography in 100 hemodynamically stable patients. In this table, I represented the minimum change that can be considered as significant for different TT variables between 2 TT examinations performed by the same operator or by 2 different operators. Let's see the VTI of the left ventricular outflow. The least change can be considered as significant between 2 TT examinations was 11% when both TT examinations were performed by the same operator. But it increased up to 14% when both TT examinations were performed by different operators. That TT is compatible with the assessment of the effect of food administration, assessed by an increase in cardiac output or in VTI greater than 50%. But TT might be not precise enough for assessing the effect of something, predicting preload.
Dr. Matthew, can we please try again with your microphone, please? Sorry.
Is it better like that?
Yes, please continue. Thank you so much. Thank you.
No worry, no worry. To illustrate the slide of one, we investigated the ability of TT to predict grid responsiveness with the respiratory occlusion test by using the VTI measurement. During the end expiratory occlusion test, VTI increased more in responders than in non-responder patients. Similarly, during an end inspiratory occlusion test, VTI decreased more in responders than in non-responders. And when we add mathematically the absolute values of both effects on VTI, changes were even larger in responders than in non-responder patients. And we found that an increase in VTI greater than or equal to 5% during an expiratory occlusion was reliable to predict completeness. And interestingly, considering the added effect of inspiratory and expiratory occlusions, allowed one to predict with responsiveness with similar reliability, but very important, with a higher attrition value of 13% in the study, value which is more compatible with the precision of TP. That it is not recommended to use hemodynamic monitoring at the initial phase of shock. And echocardiography is more a technique of hemodynamic evaluation than a technique of hemodynamic monitoring. Now, what about hemodynamic monitoring after the initial phase of shock? We have to consider two types of patients. Patients without ARDS or right ventricular dysfunction, and patients with ARDS or right ventricular dysfunction. In this latter patient, it is recommended to monitor cardiac output and thus to consider a hemodynamic monitor. In less complex patients, no further hemodynamic monitoring is required when patients are responsive to initial therapy. And if not, hemodynamic monitoring is recommended as for the most complex patients. But the question is, which hemodynamic monitoring should we consider? In this most complex patient, should we consider non-invasive techniques? Should we consider less invasive techniques, such as transpulmonary thermoevolution or uncalibrated first wave analysis? Or should we consider the pulmonary arterial catheter? Let's start with the non-invasive techniques. Such techniques include uncalibrated first wave analysis with the higher pressure waveform obtained non-invasively by the volume clamp method or by radial arterial drainage tonometry. It also includes bioreactance or bioimpedance, and finally, it includes the first wave transit time method. Overall, non-invasive techniques are not accurate now in patients with shock, and the use is limited by peripheral edema, by vasoconstriction, as well as by the movement of the patient. And for all of these reasons, non-invasive techniques should be reserved for the operating room. Nevertheless, it should be noted that new non-invasive devices are being developed for ICU and need to be maybe a little bit more reliable. For instance, this new bioreactance device, which averages cardiac index over a short 8-second period. It has been tested in 32 ICU patients before and after the passive leg raising test. First, there was a fair agreement between changes in cardiac index measured by bioreactance and changes in cardiac index measured by transpulmonary thermoevolution induced by the passive leg raising test. And second, changes in cardiac index measured by bioreactance could reliably detect the positive passive leg raising test. What about the less invasive hemodynamic technology? The esophageal Doppler provide an estimation of cardiac output from blood flow in the descending aorta. It also provides some other useful hemodynamic variables. But
its reliability is affected by the movement of Doppler probe in less sedated patients, and such technique is predominantly observed for the operating room. Let's move to the uncalibrated first wave analysis device. The pressure waveform analysis estimates cardiac output from the shape of the arterial pressure curve along with patient-specific anthropometric and demographic data. All available devices use the same principle that the amplitude of the systolic part of the arterial curve is proportional to stroke volume and inversely proportional to arterial compliance. The arterial curve is obtained through an arterial catheter, and the devices do not require any external calibration. How does it work? Each device estimates the starting value of cardiac output by using proprietary algorithms, and thereafter provides a bit-by-bit cardiac output measurement with the first wave analysis. The problem is that this uncalibrated first wave analysis device do not allow an ICU patient reliable measurement of cardiac output as compared to transpulmonary thermoevolution, as illustrated in this study by the high percentage errors with the two devices. Both of them were above 30%. In addition, such devices cannot reliably track changes in cardiac output induced by norepinephrine changes, as illustrated in both cases by the poor concordance rate below 40%. But, and it's important, it must be noted that the devices seem to be more reliable to track changes in cardiac output induced by fluid administration, as attested by the higher concordance rate. To summarize, uncalibrated first wave analysis devices only provide cardiac output, first pressure variation, and stroke volume variation. They cannot be used in patients with significant changes in vascular flow. But they can be considered to track short-term changes in cardiac output induced by fluid administration. That's the reason why uncalibrated first wave analysis devices should be predominantly reserved for the operating room. To summarize, non-invasive techniques are not accurate now in ICU patients, and uncalibrated first wave analysis devices cannot be used in ICU patients with significant changes in vascular flow. What about transpulmonary thermoevolution and lithium dilution? Currently, 3 devices are commercialized: the volume view from Edwards, the Pico from Pershing, and the Litco Plus from Litco, which is not used in France. The transpulmonary thermoevolution devices combine 2 different techniques to measure cardiac output. The first one is transpulmonary thermoevolution, and the second one is the first wave analysis. How does transpulmonary thermoevolution work? Patients need to be equipped with a central venous catheter in the superior vena cava territory, if possible, and with a femoral permissive arterial catheter. The stem dilution measurement is performed by injecting corticoline through the central venous catheter. The decrease in blood temperature is then detected by the permissive arterial catheter, and the stem dilution curve is obtained. And this is the mathematical analysis of the stem dilution curve, which provides intermittent cardiac output calculation. Transpulmonary hemodynamic is an accurate and precise method, but it only provides intermittent cardiac output measurement. The other technique to measure cardiac output is the first wave analysis, as previously described. That's very important. Conversely, using calibrated first wave analysis devices, the starting value of cardiac output is obtained after calibration by hemodynamic. And thereafter, a bit-by-bit cardiac output measurement is obtained with the first wave analysis. That first wave analysis provides a bit-by-bit cardiac output measurement. Nevertheless, you have to keep in mind that the reliability of the measurement is affected by a drift time of first wave analysis, requiring regular recalibration of the device. In clinical practice, this real-time cardiac output measurement allows to assess fluid responsiveness and allows to assess the effect of fluid administration. Just a technical point. In Europe, there is an increasing use of peripherally inserted central catheters instead of central venous catheters for several reasons. Easy and safe insertion in the peripheral vein of the arm, no risk of pneumothorax, no risk of hemothorax, lower risk of hemorrhage in patients with coagulation disorders, and lower risk for catheter-related bloodstream infection. Nevertheless, the reliability of transpulmonary hemodilution through such catheters is unknown. And a very recent study published in Critical Care Medicine a few weeks ago has investigated special forms. Transpulmonary hemodilution variables obtained through peripherally inserted central catheters are represented in blue, and transpulmonary hemodilution variables obtained through the central venous catheter are represented in red. And it has been shown that transpulmonary hemodilution through peripherally inserted central catheters systematically overestimated the different hemodynamic variables. Thus, the message is, be careful when using such catheters for hemodynamic monitoring by transpulmonary hemodilution. The great advantage of the transpulmonary hemodilution devices is that this time cardiac output measurement, the mathematical analysis of the hemodilution curve provides other useful hemodynamic variables regarding the preload and the preload reserve, regarding the left ventricular systolic function, regarding the lung water and the pulmonary vascular permeability, and finally regarding tissue oxygenation. Thus, the global and diastolic volume is a marker of cardiac preload. The cardiac function index and the global ejection fraction are both markers of cardiac systolic function. The extravascular lung water is a quantitative measure of pulmonary edema, and the pulmonary vascular permeability index is a marker of the lung capillary leak. Interestingly, such devices could be helpful for guiding therapy in much complex patients. For instance, to assess the benefit-risk ratio of fluid administration in patients with ARDS. For example, this patient is hypotensive, and this patient has also a severe RDS with a PF ratio of 100 with a peak level of 10 centimeters of water. Cardiac index is low, and the placebo gradient test is positive, since it induces an increase in cardiac index above 10%. So, what can we do for the arterial hypertension? In my opinion, one should consider values of extravascular and water and of pulmonary vascular permeability index. If extravascular and water and pulmonary vascular permeability index are not so high, one could probably consider fluid administration to treat this arterial hypertension. But if both extravascular and water and pulmonary vascular permeability index are very high, should we consider once again fluid administration to treat the arterial hypertension, even if patient has pre-observed? In my opinion, but it's my opinion, probably not. And we should rather consider vasopressin in order to avoid worsening lung edema and oxygenation. Last technique, but not least, pulmonary artery catheter. The pulmonary artery catheter provides intelligent cardiac output measurement by using pulmonary dilution. A more recent modified pulmonary artery catheter equipped with a proximal thermal filament provides semi-continuous cardiac output measurement. Nowadays, the pulmonary artery catheter is still considered as a gold standard for cardiac output measurement. It provides some other useful variables, such as the right atrial pressure, the pulmonary artery pressure, the pulmonary artery occlusion pressure, or the venous oxygenation saturation. And it is an important point again. The pulmonary artery catheter cannot reliably track short-term changes in cardiac output. Even the modified pulmonary artery catheter, despite semi-continuous cardiac output measurement, that transpulmonary thermodilution devices and pulmonary artery catheter provide additional useful hemodynamic variables in patients with shock. So, which hemodynamic monitoring should we thus consider the most complex patients after the initial phase of shock? We should consider advanced hemodynamic monitoring, either the transpulmonary thermodilution devices or the pulmonary artery catheter, preferentially in patients with right ventricular dysfunction. And this is my last take-home message. Transpulmonary thermodilution devices or the pulmonary artery catheter are recommended in the most complex patients with shock. That means patients with shock and ARDS and or right ventricular failure. To summarize, pulmonary artery catheter is very reliable in ICU patients. That's very invasive, not so easy to use, and it cannot provide real-time cardiac output measurement. The transpulmonary hemodilution devices are also invasive, but they are very reliable in ICU. They allow real-time cardiac output measurement, and they provide other useful variables from cardiac output. Invasive and calibrated first wave analysis devices cannot be used in ICU patients with significant changes in vascular tone. But in patients with contraindication to transpulmonary hemodilution devices, invasive and calibrated first wave analysis devices requiring a radial artery catheter could be used to assess the short-term cardiac output response to a passive degrading or to fluid administration. Finally, the esophageal Doppler, as well as all the non-invasive techniques of hemodynamic monitoring, are not reliable now in ICU patients, and for this reason, should be reserved for the operating room only. To conclude, what's the future of hemodynamic monitoring? This is news. News for non-invasive techniques, easy to use, and ergonomic tools, including wireless and wearable sensors, with embarked smart software and algorithms. For example, a connected t-shirt, recording CG, tablet, or cell phone, digital watch, connected glasses, or why not, wireless touch, measuring non-invasively radial blood pressure. Thank you very much for your attention.
Thank you. Thank you, Dr. Matthew. Thank you for your amazing presentation. Let's move on to the questions from the audience, Dr. Matthew.
Yeah.
Bueno, pues muchas gracias a todos por su asistencia a este webinario. Si tuvieran alguna pregunta, es el momento de realizarla a través del medio, del chat que está habilitado en la plataforma. Por si tuvieran alguna pregunta. Les pedimos una disculpa por el audio. Desafortunadamente no pudimos mejorarlo, pero bueno, pues nos gustaría escuchar algunas de las preguntas. Yo tengo una pregunta para el doctor Matthew. Dr. Matthew, one question is, what is your opinion about the hemodynamic monitoring in the typical patient with ARDS, with severe ARDS? Maybe we can use the PAC catheter in order to evaluate the pulmonary pressure, etc. And maybe our interest, or we would like to evaluate the extravascular lung water with thermodilution. In this case, maybe we should combine these two methods, or what's your opinion? What is the best method in patients with severe ARDS, which is one of the most common patients we have here in our settings in Latin America?
Yeah. The most important point is that we should monitor such complex patients. And which monitoring should we consider? I think that there is no ideal hemodynamic device. You should use the device you know. You should use the device you know how to interpret the variables it provides. For instance, I'm using thermodilution devices such as PICO because we have PICO monitoring in my unit. And if I want to use the pulmonary artery catheter, I think it will be maybe almost dangerous for patients because nobody uses longer the pulmonary artery catheter in my unit. So if I use the pulmonary artery catheter, nobody knows how to interpret very, very reliably the variables. So for me, the key message is use what you know to use.
Ok, doctor, thank you. Como ustedes pueden escuchar, el doctor nos recomienda utilizar el que más acostumbrados, el que más familiarizamos, el que más familiarizados estemos del método o que sepamos interpretar las variables, porque al final eso es lo que más interesa, el saber interpretar las variables para tomar decisiones adecuadas. And another very common question, Dr. Matthew, is how to monitor patients in ARDS, but in prone position. What method do you consider is the best method, even to track changes after a fluid passive leg raising test, or because you know in prone position is some complicated. So what's your opinion about it? What should we use in cases of prone position patients on their ARDS?
Yeah, it's a very, very good question. In fact, there is a very simple answer. Because, you know, hemodynamic monitoring has never been validated in prone position patients. But in fact, in my clinical practice, I'm using thermodilution devices even in patients in prone position. And of course, obviously, it's not possible to perform any passive raising test in patients in prone position, but it's possible, for example, to assess the preload responsiveness by using an expiratory occlusion test in such patients, even in front position. So in my practice, I'm using the thermodilution devices in order to assess the effect of front position on extravascular and water measurement, for example, on pulmonary vascular permeability index. And I think it's very interesting for physicians to assess the effects of potential beneficial effects of front positioning on the oxygenation, but also on the volume of lung edema or on the pulmonary vascular permeability. It's very important for me to integrate all these different variables to better understand how the front positioning is working in my patient.
Right. Thank you so much. Bueno, el doctor nos comenta que él prefiere utilizar la termodilución transpulmonar para pacientes con CIRA y que están bajo posición prono. And Dr. Matthew, in Europe, in your setting in Paris, in France, how often are you using a pulmonary artery catheter? What can you tell us about it?
In fact, it depends on the unit you are working. In my unit, no patient has pulmonary artery catheter, but I know some of the units in where almost all patients are monitored with the pulmonary artery catheter, and this is for a very, very simple reason. That is because in such units, patients are very used to use the pulmonary artery catheter. That's always the same key message. Do what you need to do.
Okay.
Dr. Matthew, we have a question from the audience.
Yeah.
They want to ask you about what measurement will be the best to assess by echocardiography to assess the hemodynamics of the critical ill patients.
What is the
measure the BTI?
Echocardiographic parameters to monitor?
Yeah. One of our attendants is asking, what parameter will you recommend to focus on to provide the hemodynamic assessment?
I think that the echocardiographic parameter you have to monitor is the BTI of the left ventricular outflow tract, because it's very useful to assess the effect of the different therapeutics on cardiac output. It's a way to non-invasively monitor the cardiac output. In my practice, it's not very useful to use echocardiography, for example, to assess the end-diastolic left ventricular pressure, because you know that it's not very reliable with a very, very large gray zone. So, in my opinion, the key parameter in echocardiography is the BTI of the left ventricular outflow tract.
One follow-up question about that. In your center, how many times did you measure the BTI in order to have this balance measurement of the BTI? Do you measure once, twice, 5 times?
In a patient?
Yeah, in an assessment, like if you measure only once, or you validated like 2 times, 3 times to get the.
So, I think that the main pitfall of echocardiography that you cannot monitor your patient. You can only perform hemodynamic evaluation, and you are perfectly right. If I want to use echocardiography to monitor my patient, I have to perform several times a day in my patient echocardiographic examination, and in my opinion, it's not possible because it's very, very time consuming. But if I perform echocardiography, I will measure VTI just before and just after my therapeutic, or just before and after my test to predict preload responsiveness, for example, the passive rating test. So I think once again that's the main pitfall of echocardiography, and that's the reason why I do not use echocardiography to monitor my patient. I only use echocardiography to perform the initial hemodynamic evaluation at the interface of shock, and thereafter, if I want, of course, if with my thermodilution device, optical monitoring, my parameters of cardiac function are very low or decreased, I think that it's very important to perform an echocardiography to confirm or infirm what you see in the monitor. If my cardiac function index decrease in a patient, I think that the gold standard to really assess the left ventricular function is the echocardiography.
Ok, el doctor Matthew nos comenta que para la ecocardiografía él usaría el BTI como una medida confiable. Sin embargo, menciona las debilidades de la ecocardiografía, el tiempo para realizarlo y la cantidad de mediciones que se requieren para tener una variabilidad, disminuir su variabilidad. Así que él menciona que por lo general usa 2 estrategias. Usa la termodilución transpulmonar y la verifica con el ecocardio para tratar de minimizar el tiempo y tratar de tener redundancia de datos para poder confiar en las mediciones que hicieron. Esa sería la respuesta del doctor Matthew a la pregunta de Diego.
Ok, vamos a leer la pregunta de Pablo Bravo, quien es muy conocido allá en Chile por toda la trayectoria que tiene en el uso de la ultrasonografía, al cual le agradecemos esté con nosotros, Pablo. Y bueno, él nos pregunta que si el expositor tiene experiencia utilizando el BTI propiamente, pero de la arteria pulmonar, para predecir respuesta a volumen. Dr. Matthew, from physicians of our audience from Chile, is asking about how often or what is your experience about using the pulmonary artery VTI instead of the, the left ventricle outflow tract in these cases, in order to evaluate and to predict fluid responsiveness, Dr. Matthew?
So you mean how I use the pulmonary VTI in my clinical practice?
Exactly. Instead of the VTI from the left ventricle outflow tract.
Okay, yeah, it's very interesting because in fact the pulmonary VTI is not a very well-known parameter, echocardiographic parameter, and yes, to be honest, we do not use such parameter in our clinical practice, but interestingly, a recent paper has been published with this topic, this purpose, in critical care medicine, and the team in this paper, as I said, is the pulmonary VTI could be used rather than the left ventricular VTI to assess fluid responsiveness, and the answer was yes. First, it is a very easy parameter to obtain, and second, it is a very reliable parameter to assess fluid responsiveness in ventilated patients. So it could be in the future an interesting echocardiographic parameter. But once again, to be honest, I do not use such parameter in my clinical practice.
Exacto. Ok, bueno, en la experiencia del doctor Matthew, él no lo usa frecuentemente desde su muy particular punto de vista, pero que él menciona que hay algunos artículos, algunos papers recientes que sí efectivamente lo están utilizando, que es confiable, que en algún momento puede, pues sí, puede ser sustituido por lo que normalmente hacemos a nivel del tracto, pero bueno, él comúnmente no lo hace. Definitivamente no lo hacemos muy, muy seguido. Seguramente se podrá utilizar, pero siempre, la mayoría de las veces nos vamos con los métodos más tradicionales. No sé, Luis, si quisieras también hacer algún otro comentario o alguna otra pregunta.
Yo tengo una pregunta para el doctor Matthew un poco más general. Dr. Matthew, I have a question for you, more like a recommendation. In Mexico, we have very common low income setting environment, so we don't have enough tools to assess properly the hemodynamic monitoring in the critically ill patients. So, in your opinion, if we are going to put money on training or invest in some technology, what would you recommend to do? Like focus on transpulmonary thermodilation and try to access that device, or try to learn how to do ultrasound to assess a very broad but training-dependent assessment? What will be your decision to choose between ultrasound or the transpulmonary thermodilation?
It's a little bit difficult to clearly to give a clear answer, but I think that all hemodynamic devices are very, very excellent. Even the uncalibrated first wave analytic devices. And if you want to get money in such devices, you have to buy the monitor, then you have to buy all the catheters, the arterial catheter, also the thermistor tip arterial catheter, and then for each patient you have to use the new catheter. If you want to get money in echocardiography, you just have to buy one echocardiograph and one cardiac probe, and you can use the same monitor and the same probe for all of the patients. So I think it's a better, it's a best investment for you. Regarding the learning curve, I showed in my tour that in fact it's very, very easy, even for naive physicians to learn the basics of transocratic echocardiography in critically ill patients. And that's not the same thing for the most complex and advanced hemodynamic devices. I think it's not so easy and not so obvious to clearly understand all the hemodynamic parameters that the pulmonary artery catheter or the thermodilation devices can provide to the physician. And it could be dangerous to use such devices if you are not aware about the meaning of all these parameters. You can do maybe some therapeutic consistency. So, in my opinion, if you need to buy only one device, buy echocardiography. To conclude, echocardiography can be used to perform hemodynamic evaluation, but also to perform lung echography. And you know that there is a lot of papers about the use of echocardiography to help a physician in the respiratory winning, for example, to assess lung edema. So use echocardiography.
Okay, thank you, Dr. Mathieu. Como nos comentaba y en continuación a sus trabajos y su experiencia, él nos comenta que es más fácil comprar una ultrasonografía, más en un término costo efectivo, reusar esa tecnología para hacer las valoraciones necesarias en nuestras unidades, en lugar de tratar de adquirir una tecnología ya más relacionada a la termodilución. Sí tiene las implicaciones del entrenamiento y de la facilidad y de la curva de aprendizaje. Sin embargo, hay más variables que aprender y más situaciones que considerar, tanto la fiabilidad como la adecuada medición de los procesos. Así que el doctor Matthew recomienda, si vamos o tenemos que invertir algo para dar un tratamiento a nuestros pacientes, probablemente la ultrasonografía sea más accesible y más costo efectiva, sin un argumento de datos que confirme esto, pero bajo el razonamiento de su reusabilidad puede ser muy útil adquirir uno.
Así es, Luis. Y bueno, yo le voy a preguntar acerca de, sobre todo hablando de los métodos no invasivos y fáciles de utilizar, accesibles, algo que muchas veces hasta se pone de moda, como es la colapsabilidad de la vena yugular. Dr. Matthew, what's your opinion about the evaluation of jugular vein collapsibility? Is it useful? Should we useful? Above all, speaking about easy and very available methods such as the jugular vein collapsibility, but I don't know if the evidence really supports the jugular vein, because it's very similar to evaluate maybe the central venous pressure, and as we know, the central venous pressure has many pitfalls. So I don't know, what's your opinion about it, Dr. Matthew?
Can you repeat the question about what?
About the jugular vein collapsibility. What's your opinion?
Jugular vein.
Jugular vein.
I don't know exactly what I can answer you about this point. In fact, I do not use the jugular vein collapsibility in my practice, but right. I think that as for all other static hemodynamic parameters, static parameters of cardiac flow, such as the central venous pressure, it could be an interesting parameter for the extreme values. If the jugular vein collapses a lot, I think that you can think reliably that your patient needs some fluid administration. And if there is no collapse of the jugular vein, maybe there is a reason to give fluid to your patient. And finally, it's exactly the same thing for the central venous pressure. It is well known that the central venous pressure cannot reliably predict something like that. I think that central venous pressure can be useful in your clinical practice. In patients with very low central venous pressure values, especially in patients mechanically ventilated with positive intrathoracic pressure, you can be almost sure that your patient will respond to fluid administration. And in patients with very high values of central venous pressure, you can be sure that your patients do not need any fluid administration. The problem of all of these parameters is the very large gray zone.
Exacto. Muy bien. Bueno, pues nos comenta sobre todo que, dada la correlación con la presión venosa central, todos sabemos de los pitfalls que puede tener la presión venosa central y al mismo tiempo la vena yugular, pero que en situaciones extremas de nula colapsabilidad, etcétera, sobre todo en pacientes con ventilación mecánica que tienen una vena yugular que no colapsa, etcétera, corresponde a presiones muy bajas centrales, pues desde luego que pudiera ser en un momento útil, pero bueno, no es algo que el doctor realmente esté utilizando frecuentemente. And Doctor, what's your opinion about using lung ultrasound specifically to evaluate extravascular lung water? I mean, is there a correlation among them? What's your opinion about using lung ultrasound for evaluating extravascular lung water, Doctor?
I think it would be a very interesting tool. It has been clearly shown that there is a correlation, as you told, between the line in lung ecography and the amount of extravascular lung water. And it is very easy to perform the lung it's very easy to perform lung echocardiography, and the learning curve is very, very quick. As for the quicker than for the cardiac echocardiography or for the people to obtain reliable measurement of extravascular lung water. So I think that it would be a very interesting tool, either to assess the volume of lung edema, but also to help physicians for the respiratory weaning of the patient.
Exacto. Muy bien, bueno, el doctor sí lo considera útil. Todos sabemos de que el ultrasonido pulmonar es un método cualitativo, a diferencia de la termodilución transpulmonar, que nos daría, desde luego, una evaluación cuantitativa, pero bueno, el doctor considera que ciertamente es útil. Y bueno, no sé si hubiese otras preguntas, Luis, no sé si en Facebook, parece que ya no. Pues no sé si exista por ahí otra pregunta, Luis, si tuvieras algún otro comentario. Solamente hay muchas dudas respecto al monitoreo hemodinámico en embarazadas. Quizás sería, para finalizar, una de las preguntas que habría que hacerle al doctor Matthew. Dr. Matthew, in pregnant patients, in pregnancy, what is the best method you consider for evaluating or for hemodynamic monitoring, doctor, in pregnancy?
And in pregnancy, in my opinion, there is no contraindication to use the hemodynamic devices. We would prefer even in pregnant patients.
Okay, sorry, could you repeat, please, the last sentence?
So I think that there is no contraindication to use your preferred hemodynamic device even in pregnant patients.
Ok, que realmente no hay una contraindicación para utilizarlo, si no me equivoco, Luis. Yo también le entendí eso, ¿no? Que podríamos
Sí.
utilizar realmente cualquier otro método. Bueno, pues, Luis, no sé si tuvieras alguna pregunta ya para concluir. Parece que de nuestra audiencia ya no hay. Luis, para ya dar finalizado este webinario.
No, me parece que el tema es un tema complejo dependiendo de muchas particularidades de cada etiología. Sin embargo, sí cabe resaltar que es fundamental hacer una evaluación objetiva de la hemodinamia de nuestros pacientes. ¿Alguna pregunta más allá que hacerle al doctor Matthew? Creo que ha respondido de manera excelente las preguntas que le hemos hecho, pero no se me ocurre otra pregunta relevante sin caer en la peculiaridades muy específicas de la hemodinamia. Así que por mi parte yo creo que no encuentro alguna otra pregunta interesante para discutir de manera global.
Así es. Sí, pues realmente, bueno, es un tema bastante interesante. Yo creo que lo que el doctor ha insistido mucho en sus respuestas es sobre utilizar, pues, lo que siempre manejamos en cuanto a que el método que mejor tengamos dominado, que mejor conozcamos, porque incluso lo comentaba alguno de sus colegas en webinarios pasados, de que realmente el médico no va a utilizar algo que no conoce o no comprende, ¿no? Casi siempre se va a ir por lo que él tiene dominado, con lo que él conoce, ¿no? Entonces, eso es importante hacerlo notar, que el método mejor, pues, es el que mejor utilicemos, y sobre todo el escenario, y en nuestro México, en nuestra Latinoamérica seguramente igual, pues realmente muchas veces es de acuerdo a lo que tengamos disponible, no tanto a lo que sea mejor, sino lo que tengamos en ese momento disponible. Curiosamente hay unidades que lo único que tienen es eco, que es lo único que tiene es ultrasonido. En otros no tienen ultrasonido, pero tienen Swan-Ganz. En otros solamente tienen termodilución transpulmonar, otros solamente vigileo. En fin, creo que son pocas las unidades que realmente tienen todo absolutamente. Desde luego sí las hay, sobre todo en el medio privado. Pero bueno, pues con esto les vamos a dar las gracias al doctor Matthew, también a ti, Luis, por habernos acompañado, por tu contribución. Gracias por estar aquí, por estar también, por formar parte de nuestro grupo y nuestra unidad internacional. Dr. Matthew, thank you so much for your webinar. Thank you for sharing your knowledge. We are very, very happy. I don't know if you have some last words or your last message to all of our Mexican and Latin American audience, Dr. Matthew.
Yeah. First of all, thank you very much for your invitation. It was a pleasure to be with you and to discuss with you about this very interesting topic that is hemodynamic monitoring. And my key message would be, please monitor your complex patients. Try to understand what is happening, and very important, assess the effect of your therapeutic. That use what you know to use. Do not use transpulmonary evolution devices because it's my opinion. Use what you have in your unit and what the devices you are used to use.
Exactly. Yes. So, bueno, el doctor nos comenta precisamente eso como último mensaje, que utilicemos lo que mejor estamos acostumbrados a utilizar y que pues lo utilicemos sobre todo el monitoreo en pacientes complejos. Bueno, pues con esto le damos la despedida a todos. Luis, no sé si tienen hasta el último mensaje.
No, thank you so much for your lecture, Dr. Matthew. It was an honor and a pleasure to hear you. Muchas gracias, Juan. Para mí es un honor pertenecer a esta asociación. Siempre es agradable estar en esta interesante fase de la medicina, donde la insonación se ha vuelto una herramienta que va a revolucionar el campo de una manera global, tanto en críticos como no críticos. Así que es un placer estar aquí y ser parte de esto.
Gracias, Luis. Y bueno, pues continuamos tu contribución, sobre todo para todo lo que nos queda de proyectos para nuestra asociación. Te agradezco, le agradecemos al doctor Matthew, agradecemos a toda nuestra audiencia. Sabemos que hay gente en Chile, en Argentina, en Paraguay, en Uruguay, en Colombia, en Costa Rica, en varios, muchos lugares de Latinoamérica que nos siguen. Les estamos muy agradecidos. Gracias por confiar en nuestras actividades, que siempre nos esforzamos porque sean de alta calidad. Así que bueno, pues les agradecemos mucho y le damos nos despedimos de todos ustedes y al mismo tiempo del doctor Matthew. Thank you so much, doctor. I'm going to finish the webinar. Thank you so much for being here and thank you for all your contribution to this field across and through all your fantastic literature you have published. Thank you so much.
It was a pleasure. Thank you.
Thank you. Thank you. Bye bye. Dios a todos. Muchas gracias.
Thank
Adiós.
you. Gracias a todos.
Bye. Bye.